So very good morning. I have to talk about moving towards elimination of hepatitis C virus from India. What are the challenges and way forward? These are all my personal opinion. What I look from an outsider and being a part of the national hepatitis program and being involved in the state. So these are all my personal opinion. So the story of this virus started in 1989, you all know, and then in 2020 the Nobel Prize also went. Decades only the success came. We could make a replicon, then direct acting antivirals came, and so can we actually say that are we near towards hepatitis C elimination? So what are the challenges? I'll be discussing point by point. There are a lot of success story, and I'll be talking only about the India, which is important from all of us. Launch of National Viral Hepatitis Control Program is a success story, but what are the challenges? So I'll be discussing these success stories with subsequent challenges, one by one. So we all know National Viral Hepatitis Control Program got launched in 2018. It is the first comprehensive, only in the world, which takes care of hepatitis B and C, complete diagnosis as well as treatment. So they give you free drugs for B and C. They give you free test only for viral load and virological serology testing. So what are the challenges? Definitely, so these are my personal opinions. I am not speaking here on behalf of anything. I really feel lack of administration and logistics is there in NVHCP. It looks to me more like a surveillance program than a control program. Very sorry for those who are involved. The uptake, they have not made it like a NACO, a direct program. They have made it through the health mission, state, national health mission and state health mission, which I feel is slightly inhibitory. And that is why only very few states could initiate it. Delhi state, unfortunately, has still not initiated this free testing and treatment sites. And definitely COVID-19 pandemic had delayed the efforts. Another important thing which I feel is that the supportive and pre-treatment investigations are not free. So I said that they say that drugs are free and testing is free, but there is some pre-treatment investigations cost which the patient has to bear. So this has to be taken care. There is no provision for management of complicated cases in this program. Private sector has not been involved. So whatever you have to do, it has to be through the government sector. Viral load, they are giving it only at the state viral hepatitis labs, which they declare. So there will be a report turnaround time problem. And that is why there is a lot of hesitancy to participate in this program. So this was about NVHCP. Now geographical mapping of the disease. So these were the few questions which were raised in 2018. The answers came, but are we any close to elimination? So geographical mapping of the HCV disease was done by Government of India. This is a fact sheet released in October 2021. You all can access through Government of India. They say that the national sero, and how they have done it. So they do this National Family Health Survey, NFHS 4, and the DBS cards were collected, those who were coming for HIV seroprevalence from age 15 to 49 or 15 to 54. In them, they started looking at B and C. So they identified that the entire, in the national seroprevalence of hepatitis C is very less, it's 0.32. But still, India being a hugely populated, this is a huge burden. They have identified few high spot regions like Northeast, you can see red region. And there is group 9 where Delhi comes, Haryana, Punjab, Chandigarh and Delhi, where there is slightly high seroprevalence. Now this, they have also done in this the socio-demographic characteristics, and they found it was hepatitis C seroprevalence was more in men. Surprisingly, in scheduled tribe community in urban areas, but this is what the government figures have shown. Now my take on this is that this is from the NFHS data 2015 and 16. So it's almost 8 years now. The seroprevalence statistics would have changed. They have not covered the pediatric age group at all. More than 54 years, whom we actually target for hepatitis C complications, are not included in this. And like if we see Delhi with 18 million population, and even if it is 0.6%, 1 million infected cases are still lying in Delhi, which is a huge problem. Now the next success story was that various states like Punjab, Haryana, Delhi and Manipur, they came up with the good models. Even we did decentralized testing and care model. So this was our ILBS Delhi model. We started it in 2018, but funding came in 19. And in 20, because of the lockdown, some hindrances were there because of COVID. So we tried to look at hepatitis C. What is the feasibility of providing hepatitis C testing and treatment in various settings in Delhi? This we have published it also in Liver International this year. We first tried to categorize Delhi, that where are the risk populations residing, and that is how we came down to 5 big hospitals that we involved. So most of the risk population is residing in north and northeast sector. You know, there are 11 districts of Delhi. So this is how the 11 districts of Delhi are being mapped, and we included 5 big hospitals, Maharishi Valmiki. And then you look at the blue spots. These are the polyclinics. So you have very good polyclinics in Delhi, but then they have to be feeding to these big hospitals. So we took 3-arm approach: district hospital, polyclinic and screening. We also did screening camps in Delhi. This was our flow chart. We did this study in 2019 and 20. We actually did RDT testing. We did all the treatment investigation in these big 5 hospitals at the cost at what the hospital was offering. Viral load was done. So before COVID could set up this sending samples and report turnaround time like COVID, we did it in hepatitis C. We collected the plasma samples the same day and gave the report the very same day. And then patients were put on treatment in those hospitals. Complicated cases, very few, but then we used to call with Dr. Manoj involved with us, and then his telephonic consultation to go to the hospital, and then we managed all these cases. So actually, if you see, there are 7 visits involved. We could narrow it down to average 2.4 visits. Why? Because the RNA report was being given immediately, and all pre-treatment investigations were being ushered by our data entry operators. So this was how we helped the patients. So overall, we found a seroprevalence of 2%, not the national data, which is showing 0.6. There are certain sectors in Delhi like East and Northeast which show high seroprevalence. The result was, I'll not say this is correct, because some of the doctors in Guru Tegh Bahadur had a very good clinic where they have injectable drug users coming or HIV clinic running. So that is why very high seroprevalence came. So overall, we could screen 37,000 patients, and we gave them conventional treatment, and we could attain an SVR in non-cirrhotic up to 96%. Compensated cirrhotic slightly less, and decompensated very few patients, only 3, so 66%. So this was a good success story. Then we did some modeling to understand that which model works well, and we took care of the HCV model system, and we found that the percentage RNA test and cumulative cascade retention in hospital was much, much higher than polyclinics and screen. So if you have one-stop shop, means you give all services at one hospital, doctor, treatment, investigations, follow-up, you can actually cure this. So this is a known phenomena now, one-stop shop. Then we did costing calculation with HCV calculator by Harvard University, and match. This is Markov-based modeling system. And we still felt that although arm 1 was cost effective, but still it will cost about $15,000 or around $193 to the pocket of the patient. These are the actual cost in our government hospitals for these investigations, where drug cost is not included. Drugs are provided free. So $15,000 for a hepatitis C is still a huge sum for patients. So this is how we came up. So like my take, these are my take. Pre-treatment diagnostic facilities needs to upscale in Delhi. They are still lacking. You do not have good ultrasound. You do not have good fibroscan facilities. Even liver function test and kidney function test, you have to get it done. It's difficult. The treatment site should have RT-PCR testing facilities so that there is a shorter turnaround time. We should focus on North and East Delhi more. And one should have an idea of where to send these patients for complicated cases and what to do next if they are a complicated cases, and definitely harm reduction and awareness. So this is how these are the 3 success stories and the challenges. Another success story is direct acting antivirals and even the generic drugs available in our country. So you have DAAs and you ensure, but you have to ensure compliance to therapy. So only providing free medication is not enough. You need to monitor adherence, management of cirrhosis and its complication, and screening at the community level, and behavioral change and lifestyle modification needs to be ensured. Another thing which we are not talking right now, because we are in use of these antivirals only 3-4 years, is the issue of drug resistance. We have shown that baseline RAS and genotyping is not recommended with these pan-genotypic drugs. But if you're going to use them in a larger scale for a longer duration, the resistance-associated substitution might start to happen. Then different genotype, different population, there the data needs to come up. And whatever guidelines we have made, they should be revisited after 2 to 3 years of usage of DA. This is an interesting EASL article, which is a shared study, Surveillance of Hepatitis C Antiviral Resistance and Methodologies, just now released in JHEP reports in May 2022. They revisited after 10 decades, and they included the data of about 3,000 HCV patients from 22 different countries. And you can see that the frequency of RAS increased from its natural prevalence. 37% to 60% in NS3 inhibitors, 29 to 80% in the NS5A region, 15 to 22% in NS5B for SOFO, and 24 to 37 for DESA. And nearly all the patients, they harbored RAS after treatment failure, and over 2/3 having resistance to more than 2 drug classes. Pathways to resistance including enrichment of highly RVs and selection of multiple RVs. These are a couple of baseline before the actually DA has come. We have published, and we found lower rates of RAS in our chronic liver disease to a tune of 34%, not in NS5B, only in NS5A region. CKD patient just 7.6%, genotype 6 only 3.7, and we did not see. So we are just very new country to play with DAAs, so we have not seen any association of baseline RAS with SVR. These are a few lab data. These are treatment naive, 343 cases we included. Baseline RAS was seen in 34.3, so we have 34% of these already existing. In NS5B region, you have very less resistance substitutions. These are our data of treatment experience, 73 patients who had been tested. So it is 68%. So you can see from 34% a jump to 68% if you give them direct acting antivirals. Now there is another which is not a huge problem, but still one has to look for if we are moving, is the risk of relapse or reinfection. So hepatitis C occurrence can occur both reinfection and relapse, which is defined as appearance of HCV RNA in treated patient after SVR. Relapse is when you see within 12 to 24 weeks post SVR and usually by the same genotype or strain of the virus. Not very commonly reported, less than 1%. Reinfection is more commonly reported, which is infection with a different genotype or phylogenetically distant strain, usually after 12 to 24 week post SVR, and especially in the high risk group like IV drug users, patient on hemodialysis, you will see. So the challenge is that the timeline to follow up post SVR is not defined. You just follow up a patient till SVR and you leave. So till how long a person has to be followed up after attainment of SVR needs to be defined. High risk behavior to be curbed, so a very good counseling, especially those who are in the high risk behavior, to be given to prevent the problem of relapse and reinfection. Another problem that despite, so why are we treating hepatitis C? We are treating it so that the harm to the liver is not there. But you still see hepatocellular carcinoma occurrence, although in still occurring despite attainment of SVR. So SVR is not the only factor which helps you in preventing HCC. You have age and gender. Studies have shown higher age, male factor, higher grade of liver fibrosis, fatty liver disease. There are a lot of serum markers which people are working on, like apart from alpha-fetoprotein, like VEGF, and microRNA, especially microRNA 3197, and they all have shown that apart from just the clearance of the viremia, there are some other factors also which are responsible for the hepatocellular carcinoma, and that may keep on occurring. So one has to look after these factors. So hepatitis C screening should be done offered at a much younger age group, more in asymptomatic, so that you pick them up when the liver health is still better. Initiate early treatment. Screening should be offered to all symptomatic cases, and not only to symptomatic but asymptomatic also, and treatment should be initiated as soon as possible so that the liver health is secured and the chances of HCC occurrence later on is prevented. Now the last one was that COVID-19 pandemic had a silver lining, that apart from creating a network of RT-PCR testing labs, they have strengthened the microbiology sector in making them capable of doing RT-PCR testing and started doing online reporting. So a report turnaround time is not a problem. The negative impact were there for COVID-19 in a way that it delayed the services, the program initiation got delayed, financial crunch was there, but the positive impact is that almost in every district, sub-district, you have an RT-PCR setup which can be piggybacked in this program, and decentralized testing and report information system of this COVID-19 should be made use in order to achieve the target of elimination. Last but not the least, immunity is the final solution for hepatitis C elimination. So the efforts towards developing an HCV vaccine should not be given up. It's too soon to say that we do not need. All viral infections tend to come back if there is no host immunity, and you can all see the way monkeypox is coming up. Smallpox vaccination was stopped in 1980 in our country. It was eradicated, and all the cases, so there's a jumping of species, and all the cases are in the younger. So one has to be aware of these animal viruses. So vaccination and prevention is the only recourse if you really want to eliminate this problem. And especially in developed country, most of the new infections, they occur in patients who are living with injectable drug use. So even a partially effective vaccine would lower the overall incidence. Emerging data indicate that individuals who have been cured with DA, they remain susceptible to reinfection and relapse. So you need to enhance their immunity. A very recent discovery of a Norway rat Hep C virus, which can be propagated in lab strain, and the thing is that it replicates the same way as hepatitis C virus in humans, and also shows the similar immunological characteristics. So it is a great success, and one has to do efforts towards development of HCV vaccine. Animal hepatitis, so we are not the only humans to have hepatitis C virus. We come here, 6 genotypes, and you have lot many animal hepatitis C viruses are coming, and especially the equine and the canine ones are very close resemblance to this. So one has to be prepared that yes, we can go ahead with the elimination, but ultimate eradication of the disease is still not possible if you have many similar kind of viruses present in the animal scenario. So I'll just summarize that there are a lot of successes we had in the last 2 years, but there is challenges in the form of the cost of investigations and diagnostics is much higher than the treatment. One has to look after the complicated cases and follow up for HCC, behavior lifestyle modification, and work towards development of HCV vaccine. So I conclude that hepatitis C elimination in India by 2030 is difficult, but it is possible. You require contributions from multiple stakeholders, mass awareness in public regarding preventive and treatment options, decentralized testing and treatment model has to be used, more research to go into HCV vaccine development to start. How ILBS can contribute? These are just my personal views. We can actually become a model treatment center or a state hepatitis lab so that we can offer our services like the way we have offered for COVID. Or we can actually take up the challenge of doing treatment and follow-up of complicated cases in Delhi. We can start research on biomarkers for preventive approach for HCC occurrence, and someone to initiate at least HCV vaccine development from ILBS. Thank you.